Good. Hi. So this lecture is going to be a bit different to the ones I usually give. I suppose probably for those of you who have attended previous lectures, a lot of it is just me going through SBAs and then talking through the SBAs. But this one is a bit sort of, a bit geared towards your technique and how you prepare for exams. And yeah, so I hope it's helpful. Questions I'll deal with at the end if that's all right, but if I'll kind of scan through from time to time. If there's anything that is really sort of relevant or something that can be done relatively straightforward, I'll answer them during the session if that's all right. So who am I? I'm one of the founders of Quesmed. I'm qualified from UCL. I'm very interested in medical education, clearly. Also interested in neurology and stroke. I did a research fellow job. I got into IMT, internal medicine training 2 years ago. Yeah, 2 years ago now. And I'm now a CT2 or IMT2 at St. Thomas's Hospital in London. So yeah, that's me. Quesmed, we are a question bank. We combine questions, flashcards, notes, and videos in a very intelligent way. We have now over 6,500 questions. We now have 2 offline mobile apps, and we have Anki-style flashcards. We are very excited for a new update coming up in the next 2 to 3 weeks. Been a bit delayed, and it's going to allow us to search for things via topic rather than via sort of a big specialty. So hopefully that'll be useful for you. But the point of our platform is to try and make you think about questions, think about medicine, and not just sort of rote learn. And that sort of theme will be talked about a lot in this lecture, I think, just with regards to sort of how to think about medicine. Hopefully will be useful for you. So this is our first tutorial this month. Next, on Saturday, we're doing a finals mock test, which is 50 questions with yours truly, going through some hard questions, challenging ones, more for finals and penultimate year, and then some discussions about it. And then we have drug toxicity and overdose, more emergency department stuff, and then gastro with some inflammatory bowel disease. So just go onto this link if you want to sign up. And yeah, hope it's useful. So disclaimer, these are my own views, my own personal experience. I have experience in writing lots and lots of questions and editing and teaching students. So these are not affiliated to any organization and do not replace any guidance set out by medical school. So please just take this as a personal suggestion from someone who's been in the game for a few years. And I just hope it's useful, but don't consider it the end all. Just sort of take it for how it is. Fine. Okay. Cool. So, so the 2 main questions I'll be trying to go through this tutorial is how should you prepare for your SBA exams, and then also going through the best practices for answering SBA single best answers. So hopefully it will be, a bit of focus on stuff that you may already know, and perhaps it will enlighten you about the methods that perhaps medical schools will use to set your exams and how you can use that to tailor your own revision going forward, particularly for those who have exams coming up in the next sort of weeks or months. So the first section is how should you prepare for your exams? So the first thing to say is, going along the lines of what I truly believe about medicine is that we really need to become doctors at the end of the day. And a lot of what doctors do is about trying to access the sort of higher order cognitive processing. You get information, you receive that information and you process it, you synthesize it, and you apply that knowledge to make a management plan. And that's why when you're in a ward round, you say things like subjective, objective, and then impression. So you have to make an impression and you have to make a plan, apply that knowledge. So most of medicine is really not about the recall of isolated facts. And the point really is that you need to use the facts that you have in front of you and weigh them in order to make a management plan. And to a certain extent, the single best answer questions, when well constructed, and increasingly so in the last few years, these questions will ask you to think about things and weigh things and apply them, rather than just memorize, certain details in a particular guideline. So that's the first thing I want to make you think. So always try and think like a doctor, and that's very important. And there are multiple caveats to that going forward. So this is an image that I used for promoting this event. People seem to like it a lot. And I think that it's very important because I think people always try to find that one thing that will help you to succeed, and the one thing that will help you to do better, and one thing that will help you to sort of, become the best at whatever you do. I think although clearly none of that exists, but if I was to actually sort of pin down one thing that sort of really helped me to become a better test taker, to become a better medical student, and to become a better doctor, it would be this one thing, which is going to be disappointing to you guys because clearly it's something that your clinicians will tell you about a lot, number one. And number two is something that potentially you haven't been able to do so much recently. So it is attendance, and it's actually hanging out with clinicians and doctors and speaking to them and listening to them. And really the reason I say this is because I've spent so much time in undergraduate and postgraduate exams, looking at questions and thinking, I remember one of the doctors talking about this in a ward round. And actually, I've never seen a question about it. And so what I would say is that when you have the opportunity to go to a ward round or a clinic or do something, and versus going to the library, I think you really should try and maintain attendance. Just not just because your medical school tells you have to attend, that's one thing, but actually because it's useful. And the more time you spend with people, the more time that you'll be able to learn, and the more time you'll be able to think like a doctor. And I think that's very important. And this sort of comes down to the next stage, which is about active learning. And really getting doctors to grill you is actually very useful. And I think it's quite scary because it puts you out of your comfort zone. You don't know the answer often. And then, you may be a bit potentially embarrassed in front of people you may not even know, who are your colleagues or the doctor in front of you. But actually getting out of your comfort zone and trying to get active in your learning, this is a very excellent example of it. And I suppose also, if you look at it from a sort of neuroscientific perspective, then also that relationship with emotion allows things to stick things to memory. So actually, even if it is a bit stressful, that stress will actually help to commit things to memory. So that's the one thing. I know I haven't talked about exams yet, but this is sort of a key point to start off with. So with regards to active learning and sort of trying to make sure that the things stick in your head, which has been very well established in the literature. So there's a very good book called Make It Stick, which gives a good understanding of things like test enhanced learning for practice questions, spaced repetition, which I'm sure a lot of you know already, but equally things like experiential learning is very important in the medical education literature, because it shows that it tells you that you actually learn a lot of facts by just sort of hanging out with the people you want to learn from. So really it's all about sort of testing and then review it. So this sort of concept of testing, test, review. So however you test yourself, you review it afterwards. That sort of process is really what's going to help you to learn the most. And clearly I'm very biased. I'm going to tell you to do loads of practice questions because I run a question bank, but actually practice questions are very, very useful, but also at a sort of long game in terms of finals and things like that, you really do need to spend time as much as you can in this current climate on the wards if you can. But in the meantime, if you can't do that, then questions, flashcards, and going through cases yourself, and even getting your friends to grill you as well. So as a very rough guide, as when we sort of talk about what things you should focus on in which year groups. I'm not talking about the first 2 years because it's very different for every university, but generally speaking, when you're in your first clinical year, you really need to focus on the core stuff, the differentials, the investigations. It's all about the clinical features. Management is not very important as you're first starting out. So you really need to know the sort of basic management, maybe the emergency stuff. As you go further in your clinical years, you begin to sort of figure out the specialties and the core conditions, and you need to understand more about the investigations and a bit more about management. And really, as you sort of progress in the curriculum, of course, management is important, but also you are expected to have a more nuanced view on differentials. You need to then begin to analyze things. You then begin to think about potentially some obscure conditions and how to sort of weigh those obscure conditions. And then this concept of having two-step questions where you have some features and you're expected to get the diagnosis, but then the question actually asks you for the management. So it's those sort of integrated questions, which is very, very useful. And clearly in your exams, you'll have a mix of both, but I think it's more about the focus on the sort of number of questions you'll have and what you expect it to do. So that's just a rough guide of how to think about your revision patterns, and not to be too stressed if you don't know too much about detailed management in your first clinical year. I think that's one key point. This is something that is very important, I think, because this is a meme by one of our marketing leads, works with this meme page, and he was telling me about this the other day. But basically, you sort of sit in a clinic sometimes, and you're sitting with a consultant, and he was telling me that this consultant with a very niche research interest about, I forgot what it was. I think it was like genetic heart failure or something. And then you sort of sit down and you hear about it, and then you're like, oh, the consultant really about this, and you sort of learn, and actually it's not that useful. But it's interesting, but it's actually not as useful. So really, the point I'm trying to make here is that you need to make sure that you know your foundations, and then you can consider talking about the sort of niche stuff if you have time, which sometimes you don't. So. And don't worry too much if other people around you start talking about niche stuff and you're sort of worried that you don't know. So I think that's a key point in terms of preparation, but also allowing you to not worry too much. Guidelines are a bit of a mixed bag. I think, so a lot of people, so for example, for us in our question bank, people told us, oh, we want to add the guidelines and stuff like that, which we did in the end, to be fair. But I initially always thought that, guidelines, why do you need to learn all these really obscure guidelines? And I think you need to sort of approach guidelines intelligently and remember that you need to learn the big important ones. I think I'll mention a few shortly, and really sort of don't get too bogged down by the nitty-gritty sort of details, and focus on the general picture, general understanding of sort of management, why we do this particular management and why we don't do others. So, is it because of the risks? Is it because of the fact that there may be complications, or is there like a particular study that has said this or that? So it's really about understanding the guidelines rather than getting too bogged down with the excessive detail, and also using them as an opportunity for you to sort of develop your own reasoning, which is really the point of medical school, that you understand things, guidelines, and so that you can sort of make your own decisions going forward. So that is fine. Cool. And then yes, osteoporosis management. The nice guidelines confusing. I'll do a lecture on geriatrics at some point. I did it last year. It was very comprehensive, I think, in the sense that it allowed, lots of questions to be answered by osteoporosis. So hopefully I'll do that the next couple of months. So yes, the core conditions. So what you should really be doing is in your day-to-day, when you're sort of in clinic or seeing patients or whatever, is then thinking about the thinking in your head, do I know this? Do I know the epidemiology? Do I know the signs and symptoms, investigations, and management? And taking the sort of test and review process. So, testing yourself whichever way. So, the easiest way is just to sort of, if you have your Oxford handbook, for example, you close it and then you say, okay, do I know the signs and symptoms of multiple sclerosis? The signs and symptoms are, this, and this. And then I'm going to review it, I'm going to read it, and then, oh, I don't remember that. Okay. And then, try it again and go. And so that sort of test and review. And that in itself is a very good way of you developing that broad understanding of the topic rather than the sort of details. And then as you go forward, then you can start focusing on the details. But clearly the core conditions are the most important. So emergencies, this is one that has lots of guidelines, which is actually good in many ways because it helps, it's stuff that you can just sort of memorize, even though it can be confusing at times, especially if you have different guidelines. So the main ones I would say are the advanced life support guidelines, so the tachycardia and bradycardia as well, advanced arrest and things like that. And those are quite clearly put out in sort of ALS. And then you have the British Thoracic Society guidelines, pneumothorax, asthma, COPD, very helpful. And I would say actually the Oxford Handbook for Emergencies is essentially all you need to know for in terms of emergencies, which is very good. But equally it's also useful for when you apply actually going forward. I mean, when I applied for my IMT interview, I actually use the Oxford Handbook of Emergencies as a sort of reference point. And I use that sort of test and review strategy and allow me to sort of stick things to memory as much as possible. Apart from the emergencies, also one important aspect of your curriculum, which is reflective of the fact that lots of doctors will work in GP, and lots of GP presentations that are classically for GP will also come in emergency departments and acute medicine and lots of different things. So it's very, very important to know. So again, the same way I would say is to sort of test and review, whichever way you want to do it. But one way of doing it is to sort of, write out your differential investigations and management on a piece of paper, and then putting that aside, reviewing a good resource. My favorite is a nice CKS, nice clinical knowledge summaries, and then sort of reviewing it and seeing. And then it's more challenging than reading, obviously, but it's a very good active technique to help you to commit. And the key is a sort of understanding the diagnostic pathways rather than just sort of just memorizing things by rote. So when you're reading through things, it's always good to figure out, okay, why is this the case? And actually, nice CKS does have a lot of that as well. That's quite detailed as well. Is there a question? Okay, I'll leave that to later. So when you're in your clinical years, I think one thing that's very important is that you need to not forget your preclinical stuff. And one thing is because obviously it's the foundations of your clinical years going forward, and it allows you to understand the background to things. And the second thing is that sometimes in your exams you will get questions that you think, oh no, I forgot this. I should have remembered. It's actually easy. And I think in my exams I got some obscure question about mineralocorticoid excess, I think, which actually probably if you asked me when I was in year 2, I probably would have remembered it. But by the time I got to year 5, I just had no idea. So actually, you could just sort of keep that in mind. That if something ever comes up, you can actually just sort of give it a quick read, and it's difficult because there's so much. And so yeah, the common culprits with all that is that things like neuroscience, because localization and neuroanatomy can be quite useful because it has a very strong link to clinical neurology. Pharmacology, it depends on which university you go to. Some do clinical pharmacology. At my university, we did preclinical, so it was in year 2. But I think you do actually have to know a fair amount of pharmacology practically as you, regardless. So I think it's very important to revise it as much as you can. The enzymes, I did talk about that. And then, yeah, having an understanding of anatomy. So I think when you're on a surgical rotation, it's probably reasonable to have a read of the anatomy. And I think one thing that comes up time and again is inguinal hernias and things like that. So I think it's just good to don't spend too much time on it, but just to sort of have a vague understanding of things. So if a question does come up, you may be able to have a good crack at it at least. So yeah, that's something to take into consideration. And then with pharmacology, the same sort of idea. Have a piece of paper that you write down ramipril, and then you write down mechanism, indication, contraindication, the side effects, and then you can actually sort of write it down, put it away, and have a review. One book I used, I don't know if this is still in press, is Pocket Prescriber, and it's kind of a nice little reference resource that had this this kind of outline. So yeah, I think this is the 2013 version, but a lot of it is still relevant, and sort of a nice little pocket guide is very, very helpful for the wards. Cool. So then the next question is that how are we going to oh, sorry, go back. Ooh, no, too far. No, wrong way. Yeah, okay, fine. Why is this happening? No. Okay, yeah, on the right track. Cool. So best practice for answering SBAs. So looking at the content specific stuff. So actually, when you're actually going through the SBAs, the things that you need to look out for. This is sort of maybe the juicier part of the lecture. So basically, when you're looking at the SBA, you need to think about the demographics. It's very important actually to know where you are, because where you are allows you to figure out what you can actually do. So if you're in a GP setting, for example, you can't really give intravenous stuff. You may want to give things that are oral or intramuscular, but sometimes you can give oxygen, for example. And obviously in a GP, they will have some oxygen somewhere on the most part. And then in a clinic, again, you're not going to be doing very exciting things. You're in the sense that you may need to do an arrest. Like you may need to deal with an arrest if it does happen, but on the most part, you'll be thinking more on the sort of outpatient management. And then in the emergency department, things are a bit different. So it helps to actually go to these places, which I'm sure you will all go to these places, so you know what sort of things are done. And then when someone comes in with your presenting complaint, I think it's very important to sort of take a moment to think of your differentials. So when you're reading a question that says, a patient comes in with shortness of breath and they're 35, just stop for a second and think, okay, what could it possibly be if they're 35 and they have breathlessness? Okay. Could it be pulmonary embolism, for example? They're young, maybe something like that, and just sort of have a quick think about it, and then move on to the next bit. So always having this thinking of sort of ruling in and ruling out. I'll talk about this in a bit more detail later. And when you're thinking about investigations, you need to really read the question in terms of what's actually asking you. So there are certain things that they will ask you sort of definitive investigations, and these are the ones that sort of will help you make the diagnosis. There are not that many things that are sort of definitive investigations that will, 100% tell you the diagnosis, but there are things that sort of certainly like definitely give you the diagnosis. So for example, I think if you're doing a CTPA, for example, for pulmonary embolism, it doesn't always give you the answer, but I don't know exactly what the numbers are, but essentially it does. So it's a very, very good sort of definitive investigation. Whereas, for example, an ABG or a D-dimer will not give, they may be sort of the next best investigations, but they're certainly not the definitive investigations. In terms of next best, yeah, it's good to know certain guidelines, of course, but also you need to sort of use your understanding of investigations to know what to do next. We'll talk about that in a sec. And then the two questions that you should also ask yourself is it going to change management now? For example, ABG in a COPD. So if the ABG shows evidence of acidosis with the context of hypercapnia, then patients may be considered for non-invasive ventilation. So therefore, it will change management, and therefore it is the next best investigation in certain patients. And then the other question is what will kill the patient first, and that's something to ask yourself. So you need to kind of always be asking yourself questions, and that should sort of be a reflection of your own inquisitiveness in the wards, and so ask the doctors the questions so that you can ask yourself the questions, if that makes sense. And that's sort of going back to the weird trick I was telling you about earlier. So yeah, so this is a group of investigations that you may have seen time and time again. And really, I mean, of course it's good to know lists and understand lists and be able to give them out if asked. But really for you, it's really important for you to know when it's used, why it's used, how important is it supportive, is it definitive, and does it change management? So if anyone ever tells you about it, ask them and say why. You need to always have that sort of why, and then so that you'll understand it, internalize it, and then you can externalize it via your single best answers or OSCEs as well. And then one other thing which I use, this is a sort of helpful rule of thumb, is that if someone ever asks me about the order investigations, I would say I would use this BBBII. It's probably more useful for OSCEs, but actually it's useful again just as a thought process. So you think about the more simple stuff, and then the sort of later on. So for example, if someone was to ask me, I don't know, how would you treat someone with pneumonia? I would say, I would start off with taking a full history and examination and checking the observations. I would do an ECG. I would check the blood glucose as part of my ABCD assessment. I do a urine dip. I do some blood tests, food blood count using ECRP. I do an X-ray, and then invasive. Not really that much for pneumonia unless it's severe, but you could do if they've got pleural effusion, you could do a pleural tap, or if they have very bad pneumonia, not sure what the cause is, you could do a bronchoscopy. You get very, very niche, but so these are the sort of things that you think about going forward, and those are the sort of that's a good way of thinking about it, because you're not, if someone asks you how would you investigate a headache, you wouldn't go on to say brain biopsy. You would always start with the other stuff first, because brain biopsies have high risk of morbidity and mortality. So not so much mortality, but it can cause a lot of damage. So you need to start with the simplest stuff first. And then again with management, again, more useful for finals, but good to have an understanding of it, is that when you're thinking about things, someone asks you what the management is, you need to be thinking conservative, which is simplest stuff, medical, and then surgical. So medical is usually sort of drug therapy, and surgical later on. And then emergencies, as you probably know, ABCD first, and then everything else. So yeah, that's management in a nutshell. So I think when you're, how many times have people told you to read the question? And probably I didn't as much. You sort of, I think reading the question stem is very important, and going back to what I was saying about the next best step and the definitive investigations, and also the thing that I wanted to mention as well, which I'll talk about a bit more and later, but on the next slide, is that the thing about sort of unusual presentations. Sometimes you can get some very weird presentations. I need to sort of know how to deal with it. So sometimes what I do is that I sort of have a quick read of the beginning, and then I sort of read the question stem and then go back so that I know sort of what I'm looking for or what my thought process should be. Yeah, so that's something that you can do as well if that suits your style. For me, it did work, but you may want to do something else. So this is a SPA that someone had sent in, I think, by Instagram. Or I think I got involved in it somehow. I can't remember. But basically, I thought it was a good SPA. So should we do a poll, Millie, if that's all right? And then we can just sort of see what people think.
I'll just give everyone a minute to read it.
Yeah, absolutely. Cool, let's see what people think. Right. Cool. Should I have a look at the answers to see? Cool. So I think 57% have gone for C, which is called Aquinas, and then 24% have gone for E, and then 10% for A. Cool. So yeah, that's the answer, called Aquinas Syndrome. And I think this is a really nice sort of thing where you have a lot of things going on and you're not really sure what, there's so much information, but actually there are certain things that point you towards diagnosis. And in a way, it sort of all comes together quite nicely in this question, even though it's not so straightforward. So, there's so many things that point towards called Aquinas syndrome, but it could also be a few other things. So, for example, you've got someone with, back pain that radiates down both legs, but weirdly on the right more than the left, and he's got numbness over the buttocks. He has some frequency of micturition, and he's got reduced power in both legs, and both ankle jerks are reduced, and then sensory seems fine actually. So basically the point is that it sort of all comes together, and then so in your head you're thinking, okay, this sounds like Coda Aquinas, cool. Is there anything? Then you think, okay, all this stuff has helped me to move my thinking towards Coda Aquinas, but why is it not the other stuff? So for example, with motor neuron disease, it can't be motor neuron disease because he's got some sensory dysfunction, because it's a purely motor dysfunction. Demyelination is less likely because he has back pain. You don't usually get pain. You may get it sometimes, but it's not a very sort of clear sign. And then maybe less likely in a sort of 4 to 6-year-old male, may expect it more likely in a woman, for example. But also the most important thing with demyelination is that you would not expect lower motor neuron signs, because with reduced ankle jerk, you'd expect upper motor neuron signs. With a cerebral tumor, you may, unless it's massive and it's the whole brain, you'd expect it normally to be on sort of one side. So you wouldn't expect things in both legs. So therefore it's less likely. And also you would expect upper motor neuron signs. And then finally, with subacute combined degeneration of the cord, it's less likely because you would expect sometimes mixed upper motor neuron, lower motor neuron with sort of maybe reduced power and also some positive sort of brisk ankle jerks, for example. And also there's not really much to tell you about sort of B12 deficiency or anything like that. Full blood count is normal as well. So basically the point I'm trying to make is you need to sort of have a rough idea about what you think it is, like have this sort of general view, and then sort of thinking about rule in and rule out diagnoses based on your ability to weigh things, and also your ability to sort of figure out what's important and what's not important. And so see how I sort of used those facts I knew. So I knew motor neuron disease can't have sensories, therefore it's not. And I'm very confident that it's not. And I think a lot of you sort of probably felt the same way about that. So yeah, someone has said his sphincters appear normal. So this is one thing that comes with clinical experience, is that, if everything else sounds okay, but the sphincters are normal, does it still mean that it is? Does it, is that a rule in, rule out thing? Is it that important that the sphincters are abnormal? So basically the point is, in real life and in exam questions as well, it's not always a sort of classic case that you get. It may be a bit different. So, if 80% of it matches, then in fact, on the most part, it will probably be the right answer. So it's all about probability and weighing things rather than sort of being 100% sure all the time. That's what we do in clinical practice as well. And these are sort of two sort of rules of thumb that people use to think about clinical decision making. So Occam's razor is sort of a thought process that says that the simplest solution is always the best. And you sort of always try and put things together in a nice package if possible. But then the opposing thing is Hickham's dictum, which is sort of a counter argument to it, that says that a man can have as many diseases as he damn well pleases. So the point is that you should try as much as you can to make things simple and have one diagnosis, but sometimes that's not possible. So, and that comes to your ability to, your experience and your ability to weigh and think through things, and not sort of hone in on a diagnosis too early and then disregard all the other stuff. So try and keep it simple as you can, but understand that sometimes it may not be the case. In this particular scenario, so the simplest solution all sort of came together in a nice way, Cod Aquina, cool. But there are many cases that's not the case, and it will be a bit harder to differentiate because you can have sort of conflicting elements. And then, yeah, so the rule in, sort of rule out thought process I was talking about. And then just one last thing with regards to this is about the concept of sort of hard and soft signs. So there are certain things that really sort of help you to weigh things appropriately. So if someone says they've got absent pulses, that is a hard sign. It's not something that you sort of, it's not subjective. That's something that someone actually cannot feel the pulses. And that's something that will make a vascular registrar, jump up and come and see the patient now. And equally, 1 out of 5 power in the right limb is a hard sign. Whereas there are certain things that can actually be a bit sort of softer, in the sense that they can be indicative of like really, really severe organic disease, but also can be essentially just a bit of, abdominal discomfort, a bit of fatigue. And dizziness can go either way. So that's why people get a bit sort of anxious by dizziness, because, what kind of dizziness is it? Is this a stroke? Is it not a stroke? Is it something else? And that actually causes quite a lot of confusion in the emergency department. So really, your ability to weigh information and make sense from all the noise that's coming out in front of you, it's very important. And this is equally true when you're doing OSCEs and you're examining someone, and if they're a bit slightly wobbly, yes, that's helpful, but actually maybe the thing they should really, really focus on is the 1 out of 5 power, if that makes sense. But clearly, there are caveats and every patient is different. And that's how you need to sort of start thinking. And yeah, of course, if we're talking about rules of thumb, we have to use stereotypes unfortunately, to raise our indices of suspicion. So clearly we have a man here with an athlete who collapses, it's hokum, isn't it? South Asian man, unfortunately, the stereotype is TB. A publican is someone who drinks a lot. The last two are a bit more niche. I don't know if people know what I'm referring to. Recently traveled from Russia, Does that ring a bell? So classic, it's a bit niche. Classically, it's people who have sort of like amoeba, sort of amoebic abscess, amoebic diseases, bit niche. And then SWAM at Lake Malawi is also like schistosomiasis. That's sort of the classic. But actually, bit niche, you don't really need to know. But these are just sort of things that I thought that would be, interesting. Apart from the first two, which are the classic ones, as it were. Okay, so yeah, so basically with all that in mind, in terms of this section, if it all comes together nicely, more likely to be correct, but really you need to rely on your own clinical reasoning and practice, and largely clinical practice alongside sort of questions and things like that. So talking a bit more about exam technique, I think that I think there's only two bits that I wanted to mention with this in this section, which I think are important. This is probably the biggest thing, time management, because if you don't manage your time well, you will probably struggle in the actual exam. So goes without saying. I think one way of doing it is actually doing time tests before you do your actual exam. And I think it's a good way of knowing how well you can understand things and how well you can get through a lot of information. So I would recommend you practice this as much as possible, but clearly adults and you've done this before, so I'll leave that to you at your discretion. But this is something that I really rate and I use it a lot. And this sort of it relates to what I was telling you about earlier. So let's read this question for like 2 seconds or more than 2 seconds. Yeah, so he's got, we don't need to do a poll or anything. So it's just heart cells 1 and 2, ejection systolic murmur, loudest in the left intercostal space, radiates to the carotid arteries. Before we even know the answer, before we even look at this, we know that it's probably going to be a particular cause of the murmur. Does anyone know? Any ideas what this could be? Hopefully this is, yeah, so aortic stenosis, AS. And so therefore, you've covered everything, and then you, so basically the point is to cover your options, and then you uncover it, you see aortic stenosis, woo, okay, very good. And then you sort of, and that's for an easy question. I'll just sort of to demonstrate it. But what if we had a really hard question? So this is a really hard question. You will find this difficult. It is difficult. Don't worry too much. Let's not do a poll actually, because then this is just something sort of as a mental exercise. But I will give you some time to just read through it. Okay, so I guess before we go on, does anyone know what the diagnosis is? So that's the sort of first step. Or does anyone have an idea about what it could be? Cool, okay. So yeah, squamous cell lung cancer, fine. So people have an idea about actually what it is. So you've got lung cancers, yeah, so people are thinking good. So SIADH, some people are saying, okay, could be SIADH, fine. So those are some thoughts. So before you even look at the question, the answers, you sort of know that you have a understanding of what it could be. So you have this in your mind, you're thinking about things, and then afterwards, have that in mind, you think, okay, how am I going to rule in and rule out things? And then you look at the choices. So these are the choices that you have. So you're saying, which of the following would be specifically associated with diagnosis? So note that the question is not asking you what the diagnosis is. So let me just give you another sort of maybe 30 seconds or so, just to sort of read through and think about things. Cool, okay. So fine. So hopefully you guys know how to read a thing, so that's cool. So I think, so basically the diagnosis here is probably, if you're looking through, so he's got, smoking history, cough, sputum, sweating, okay, lung cancer probably, fine. And then thirsty more than usual, passing urine, difficult to pass stool. And then, 6 out of 10 on the acute mental test, and he's got finger clubbing. Finger clubbing is a bit sort of random in the sense that it could be anything. Lots of diseases cause clubbing, as I'm sure you know, but not COPD. I think someone said SIDH. So, but it's less likely to be SIDH because there are some other weird things going on. Because there's difficult to pass stool. Why are they saying that? Why is he confused? Do you get confusion in SIDH? Probably not so much. So does anyone sort of have any ideas or more ideas about what it could be? Okay, so yeah, people are talking about stuff, fine. So yeah, cool, excellent. So someone's saying hypercalcemia from the malignancy. I think that's the simplest sort of explanation, isn't it? Because that is the explanation for everything. Because they're thirsty, they're passing more urine, they're finding it difficult to pass stool. They got 6 out of 10 on the acute mental state test, so they're a bit confused. So it's more likely to be sort of hypercalcemia. And then with that in mind, you're thinking, okay, this is probably more likely to be something like a squamous cell carcinoma. So then I need to think about what is associated with squamous cell carcinoma, of which the first one, cold autonomous myalgia, is more likely to be patients who have thyroid issues secondary to small cell carcinoma or small cell lung cancer. And B is associated correctly, associated with squamous cell carcinoma. C, proximal weakness and weight gain, again, more small cell when you're secreting sort of steroids. D is a sodium of 126, which is more in keeping with SIDH, again, small cell. And then hyperflexia and weakness improving after exercise is Lambert-Eaton syndrome, which is again associated with small cell. So actually the answer therefore is B. But you see how complicated the question is, but actually if you sort of broke it down, you actually have a reasonable idea without even of what it is, and you think, okay, this is likely to be squamous cell. So I think a lot of you actually got squamous cell to start off with, but maybe less of you will have got the sort of hypertrophic pulmonary osteoarthropathy because it's such a hard question. It allows you to sort of use the facts, weigh things, and also sort of put it all together in a simple way. So hopefully that sort of culminates in the stuff I was sort of teaching you in the past sort of, I don't know how long, 45 minutes now. So yeah, hopefully that sort of thought exercise is helpful going forward. And then the last bit of the lecture, if we, as we sort of are nearing towards the end, I'd like to just talk a bit about medical schools, sort of setting how they set your exams and how you can use this information to your advantage, and maybe some of the mistakes I made as a medical student, which I would not recommend. So how do they set your exams? Basically, what they do is they look through, this is a paper from the GMC, which is a bit old now, actually, 2013, 2014, but I think it's very relevant still, in that the assessments of all they basically looked at all these medical school assessments over the UK, and they sort of mentioned that all the assessments not only looked at knowledge, but also looked at professionalism, prescribing, and clinical domains. And basically, the university has these blueprints that they have to sort of map to the GMC curriculum. In the past, it used to be Tomorrow's Doctors, but I think that's been replaced now by Outcomes for Graduates, which is found on the GMC website. So the idea is that in some form, these things, particularly professionalism and statistics and all the random stuff, has to be assessed somehow. So if it's not assessed in your OSCE, for example, then it has to be assessed in your SBA. So therefore, or in the sort of multiple choice section, therefore, somehow it will come up. And because medical schools have to go to the GMC and show them that these things are met. And that's why these blueprints are very, very important for your medical schools. So Outcomes for Graduates in 2020, you have, I've just sort of copied a bit here, but what do they say? Must be able to apply social science principles, methods, and knowledge to medical practice. They need to be able to apply the principles, methods, and knowledge of population health and the improvement of health and sustainable healthcare to medical practice. They need to describe the population using basic epidemiological techniques and measurements. So it's the GMC and your medical school telling you that this is going to be examined. So you best learn them, basically. So don't forget to use this and memorize, or not memorize it, sorry, but understand this important concept when you're preparing for exams. So And another thing that they said, which I found was very interesting, again, it's a bit of an old report, but I think it's very important. And they said, we believe the greater use of statistics at individual question level and a more planned approach should help schools achieve acceptable reliability and content validity in shorter assessments rather than longer exams. So basically, they know that statistics are something that sort of differentiates between higher achieving and less achieving students at the item level and helps to make shorter exams. So basically, when you're revising, don't forget the statistics. I thought that was a really interesting point. Again, a bit old, but I think the principle does still remain. So what does that mean for you? Do not neglect what you assume to be minor aspects. I think I did this a lot, which was bad. And then there are certain things that the university needs to include in your assessment, and it will definitely come up. And there are certain lectures that you will come across in your course that are really random. So in my finals, I had this occupational medicine lecture, and I had a question on paronychia that came up in my finals, which is bizarre. But actually, when I looked back, we actually had a lecture on occupational medicine, which I attended, but I did not review. So basically, consider these random lectures as ways for the medical school to tell you that this will be assessed. And a lot of it is easy, but you just have to really read it, understand it. And then, these are the stuff that adds up: sociology, psychology, professionalism, legal stuff, and then statistics. So those are the sort of things that perhaps are a bit more neglected and actually really can help to differentiate between candidates. And I think universities are aware of that because they're harder. But actually not necessarily hard, but I think just people maybe don't expend too much time on them. This is a really important slide because this is a mistake I made. Basically before my finals, I just finished all the undergraduate sort of questions. There are certain question banks which I will not name that just are a bit random and have really random questions like that. So I was like, okay, I would like to try the MRCP questions. And in retrospect, I enjoyed it, but I think I enjoyed it because I like medicine rather than because it was very useful for finals. I learned all these like niche conditions and random stuff, but it was not that useful and I wasted a lot of time. And then with that in mind, if you go to lectures and then there are junior doctors who deliver very, really niche material, not always, some people do, some people don't, but just to tell you that if you think someone is delivering something that you think is very niche, you probably don't need to know it. The likelihood is you actually probably don't need to know it, if you haven't heard about it through med school. So don't stress about it too much. I think maybe in my first year when I was in F1 and I started teaching, I think I tried to maybe deliver too much niche stuff because I think I felt that this is the stuff that's really interesting. You guys should need to know, but actually you don't. So really stick to what the medical school is teaching you, and don't worry too much. I think. So with that in mind, towards the end of this section, make sure to follow your medical school's blueprint, whatever they give you, and then don't worry about the niche stuff too much, and then focus on clinical reasoning. Spend time reviewing the random lectures and actually understand stats. They're hard. So we did a lecture on it with Study Hub last year on medical statistics, which I think is still on the YouTube channel. Have a look at that. It was really good. Is a chap called Nico, who's a medical student, but also a scientist before medicine. Very, very good. So yes, conclusions. Active learning. Okay, please, give me feedback, please. Thank you, and I appreciate it. So thank you, Katerina. Cool. Okay, so active learning. Hang out with doctors. We're cool. I'm cool, I think. Maybe not so cool anymore, according to my brother, who's 22. We also focus on your core conditions. Don't be niche. Reasoning. Minor lectures are important. Use the cover on cover method and do lots of practice questions. So those are the things that I would say. Okay, so just to go through the questions, by learning foundations without refer to physiology, yes, physiology is important, but the main thing I was really referring to was about the sort of core conditions in medical school, sort of the key ones that you see time and time again. What would be important to learn for first year clinical? Not really part of my lecture, I have to say, but the most important things, to be honest, is what the medical school gives you. It's very, very variable. And that's really why I didn't talk about it too much now, because it's so different in each medical school. So I won't be able to comment on it, I'm afraid, unless I sort of make a whole new lecture about it. It's quite niche. So when I say stats, do I mean like p-value? Yes, I mean like p-value. And I would, yeah, so the p-values, confidence intervals, cohort studies, and what else? Lots of stuff. And yeah, someone's asking about the statistics video. I think it's on if you go to the YouTube channel and just type in medical statistics, or just look up medical statistics, it's there. It definitely is there, I think. I think it's also on the Study Hub website. But yeah, I'll get the link and I'll post it on the Facebook group as well. How do I recommend learning anatomy? I think going through. Okay, cool, fine. And then how do I learn anatomy? Again, not really part of the lecture. I'm gonna pass. I'm sorry. Very broad topic. I'll cover it some other time. Any place where we can find a list of the core conditions that we need to know. A good sort of rule of thumb is the Oxford Handbook, but a lot of it is actually stuff that the medical students, medical schools will give you. So the blueprints that should help you in terms of the core conditions that you need to know. Okay, what should you aim to revise just before exams? What should you prioritize? I think you should revise the core stuff. So all that really is in the Oxford Handbook. Do questions, and then sort of don't veer on the two really niche stuff. Prioritize, I think, the core stuff. So, you know, obviously the cardiology, the respiratory, the gastroenterology, the emergencies, the GP stuff, and I think those are the core stuff. And then later on, you can focus on the more obscure things. Depends on which exam you're doing. So. How much harder is MRCP compared to medical school finals? How big is the step up? My medical school is really geared towards MRCP because they taught us loads of niche material that wasn't actually useful for finals, but really useful for MRCP. I think that the way that I think about it is that the harder questions in finals, like the top 25% hard questions in finals, are the middle 50% of MRCP, if that makes sense. So actually, you know, if you're a medical student, you could probably answer yourself quite reasonably, maybe like 30 to 40% with your current knowledge in finals, and it's just sort of that step up depending on how interested you are in the material. That's how I would say. If you're a third year in the first clinical year, how should you use Quesmed compared to final years? I think in your first clinical year, you should really be focusing on one, understanding all the facts and why we. You know, there are certain facts about epidemiology and investigations, and features and management. But also, when you're looking through the questions, read the explanations from each choice, tell you why it's right and why it's wrong. And hopefully that acts as a bit of like an understanding for you to say, to think about why it's wrong. It's as if you're sort of asking a doctor, why is this right and why is that not right? So I think focusing on understanding really early on, whereas in final years, I think by the time you get to final year, a lot of the questions are probably sort of straightforward enough and you're just sort of tweaking. So when you're in final year, you may not want to sort of read things in terms of explanation in too much detail. You just want to read exactly, you know, why did I get this wrong? I got this wrong because of this. Okay, moving on. Whereas in your first clinical year, I would really recommend that you read through the explanations in a lot of detail. And then do the flashcards as well so that you can memorize things as you go along. So any advice for SAQs? I'm afraid I have not had any experience in SAQs, so I'm going to pass that question. And would you, in someone who prefers to understand things and that takes time, would you recommend abandoning that before finals and just doing Q banks? I'm someone who I have friends who are like that. So they prefer to really understand things, and that takes a lot of time. I think that no, you should not abandon that before finals and just do Q banks. I think there's a role for question banks, and I think the best way of doing it is to try and sort of do it coincide, like alongside it. I think one thing that some people do, which I don't really believe in so much, and there's actually is that they sort of do things in a really sort of regimental way. They'll sort of be like, okay, I'm going to understand everything now. I'm going to finish understanding, and then I'm going to do question banks, and then I'm going to do my exam. But actually, there's a lot of good research. Again, if you read that book I mentioned, Make It Stick, it's about interleaving practice to help you to remember things and understand things. And basically, if you sort of understand things, do some questions, understand things some more, do some more questions, that's actually a much more powerful learning method. And there is a lot of evidence behind that. So don't just take it from me. So yeah, try and mix and match things as much as possible. And equally with stuff like videos and things like that, I think that'd be helpful. And then finally, with obstetrics, gynecology, pediatrics, and psychiatry, it's a sort of a slightly different bag, because I think those ones are a bit more sort of consultant-led. You're maybe less likely to be expected to manage patients independently. So therefore, you will not be expected to know the sort of really, really deep management aspects, but you're much more expected to focus on maybe more, the equivalent of the sort of first clinical year, which is sort of the clinical features, the basic management, the basic investigations about what you would do, and then having a rough idea about the more detailed management options. So I think that those sort of things, again, it's the one really useful way, and I found it, was to actually, again, spend loads of time with doctors. And then I sort of have an understanding of what the consultant knows, what a reg knows, what an SHO knows, and then what I need to know. And therefore, you can sort of optimize your learning in that sense, rather than just sort of read lots of books and assume that you need to know all this really obscure stuff about whatever, preeclampsia, for example. And then you sort of, because you've spoken to an SHO who is, 2 or 3 years, your senior, who only knows this about, preeclampsia, not all the details. So you can sort of calibrate your knowledge based on that. So yeah, I hope that's helpful. Cool. Okay, guys. Please give me feedback. I'm really interested for this particular session in terms of the feedback. So if you can just fill it in for today, if you haven't done so, that'd be very, very helpful just for me. Because these are sort of the more sort of random lectures that I've given, and I just never know if it's a good lecture. I hope it's good, but yeah, if it's not, let me know. Okay. Cool. Dismiss that. Cool. Thank you so much. Thank you. More of these lectures. Okay, can do that. Thank you. We will see you if people are coming on Saturday. So the finals one, that'd be cool. And then I think I'm doing a lecture tomorrow on neurology somewhere. Yes, the British Indian Medical Association, neurology, if you're interested. Otherwise, yeah, doing a few things here and there. Does Quesmed subscription give access to the videos? The videos are all free on YouTube. I think we're working on some video content to be added to the site. Literally like 90% of the videos, 95% of the videos we've done are all on YouTube for free. And we intend to keep it that way, to be honest. What have I specialized in? I'm doing internal medicine, which is a 3-year training program, and I hope to do neurology going forward, which is why I'm very interested in the thought process behind medicine, as you can see. So that's what neurologists do a lot, even though sometimes they don't teach it very well. Good luck. Thank you. You too. Would I recommend the mock exam on Saturday for a 4th year? That's a difficult question. It depends what you like. If you're the type of person that gets really stressed out by difficult questions or the challenging questions, then maybe not. If you're the type of person that is okay with getting a lot of stuff wrong, I don't know if are you 4th year as in like first clinical year, or is that 2nd clinical year? I think that's a big distinction, as in 3rd year versus 4th year. I think if you're in your penultimate year, if that's what you mean by a 4th year. So yeah, 2nd clinical, yeah, I think that should be fine, actually. I think they're challenging questions, and yeah, they'll just help you to sort of up your game a bit. I don't think it'll be too difficult, no. I would, yeah, definitely 2nd clinical, having been, in the game for 2 years or so, I think it should be fine. If you're in your 1st year, I think, then I think it might be a bit challenging. But again, it really depends on sort of, are you the type of person that likes to sort of challenge yourself and do harder questions and sort of think about things? I'm that type of person, so I will always go to a consultant, and even if I don't know anything, I'll still go for the experience to learn, because I always find that. So getting things wrong for me is fine. I think some people may not like that so much. In the early days of Quesmed, our questions were really hard, and people didn't like it a lot because they were like, oh, I do other question banks and I get 80%, 90%, or I do your question bank, I do get 60% or whatever, and that stressed people out a lot. So I feel that yeah, so that's why we made the questions a bit more sort of relatable, and then sort of slightly easier for people so that it's a bit more relevant. But yeah, definitely up to you. Sorry, a very prolonged answer. could have been answered in a few sentences. But yeah, hope that's helpful. Feel free to come along if you like. We will be recording it as well, and then putting it up as like a premium purchase thing to cover for video hosting and stuff. So if you can make it, yeah, we'll put up some details later on. Cool. Any other questions at all? Anyone? Kept to time. Great. Damn. Okay. Cool. Okay. If there are no other questions, I'm going to head off. Please fill in my feedback form. Is there anything else you need from me, Millie? Or
no, all good. Thank you.
Good. Oh, one more question there. What level are Quesmed questions aimed at? So we've got 5,500 clinical questions. So I'd say the majority is clinical, mainly for, anywhere from first clinical year, second and third clinical year. And then the 1,000 questions for preclinical students. That's more for sort of biochemistry, pharmacology, physiology, and also we have anatomy flashcards. And then throughout, that's 15,000 flashcards as well. But those are sort of, yeah, half and half, I think, so far. Cool. Right, so I'm going to head off. Thanks, guys, and I'll see you at our next session. And yeah, see you soon. Okay, thanks, Millie.
Thanks, Yezen. See you later.
Bye, take care.